presentation in just a second. But I wanted to just give some context to this work. So we were interested in this issue of how optimally to pay physicians. I've worked under fee-for-service and under a salary plan. I have felt the pull of fee-for-service and the differences of trying to achieve a target income and how one sets up a practice for that, as well as salary and how that might impact our likelihood to call family physicians instead of see patients at times. And I certainly know from how we've set up our call schedule in nephrology that our payment mechanism drives a lot of the reasons why we set up our call schedule, not just patient care. But a story that I recently heard from a friend actually reminded me of the importance of this. And this story is probably just reflects one very end of the spectrum, but a person had some foot pain, went to see his foot doctor. They felt he had tendonitis. They did an ultrasound. The ultrasound suggested he needed a bone scan. Went back to his foot doctor, who said, well, I think we should do another ultrasound. Back to the foot doctor, who said, I think you need a steroid injection in your foot. And he said, okay. But that doctor didn't do it, so he sent him to a radiologist who did that. He went to see the radiologist who assessed the foot and then ordered an x-ray and then ordered another ultrasound and then saw him back after that and said, I think you need an injection. We have to book that for another day. We'll be using ultrasound for that. And my friend said, like, is this the most efficient way to be dealing with this problem? Does everything have to get repeated? Do you get paid for everything you do? And obviously there's more to that than just that as to why a physician might repeat tests, but it does, yes, we do get paid for everything that we do. And as Amity and I started planning this work, it's actually really difficult to have a study that accurately assess everything physicians do within both systems. In hospital, you look after patients, but you hand them from one doctor to the next who might be under a different payment system. You see patients with a zillion different problems. One family physician might always refer to a certain kind of specialist. And so with the work that Amity is going to be describing today, we tried to take a very homogeneous set of patients who are seeing a relatively homogeneous set of physicians who always saw the same patient. And so with that, I'll introduce Amity Quinn, who is a PhD. She did her PhD at Brandeis outside of Boston. In her PhD, she worked on payment models for substance use disorders, and she was awarded the IHE postdoctoral fellowship last year, and this is one of the studies within that postdoctoral fellowship. So take it away. Got very complex microphones and cameras. Technology's gone up. See if we're getting value for money.
All right, now I have to put the slides up. Start from the beginning. All right, so thanks everybody for coming. As Braden said, I'm Amity. This is my 1-year anniversary of being a postdoc here, so I'm really excited. It's been a good year, and I'll talk to you guys today about the main project I've been working on. And if some of you were at the Alberta Health Economic Study Group, this is the same work, but we've taken the feedback from that and made a bunch of changes, and also have some preliminary cost data to add on. So exciting stuff. So. Okay, so I'd also like to acknowledge my other co-authors, and as Braden said, I had gotten the Institute for Health Economics postdoctoral fellowship for this work, so that's been supporting me over the past year. So our outline for today is first I'm going to review some key messages from the work, and then talk about the background, research objective, methods and results, and then our conclusions. Thanks, Sarah. Okay, so our key messages. So the main issue at hand, as Braden introduced, is fee-for-service. You get paid for everything you do, so you might be doing a lot more services than maybe you need to do, or maybe you are doing as many as you need to do. But as costs of healthcare are increasing, especially for chronic diseases, Fee-for-service, while it's a dominant payment model, it might not really be supporting the type of care that people with chronic diseases need, because it doesn't really support coordination. It supports this doing more and more types of services. So what we know from background research is that fee-for-service does incentivize high volume of specialist physician services, but the effect of quality on quality and cost isn't really well known. So what we've learned through the research that I'm going to be presenting today is that the salary-based payment model, which in Alberta is called Academic or Alternative Relationship Plan, or ARP, is associated with a lower number of outpatient visits, but in quality of care is actually similar between fee-for-service and ARP physicians. And we also found that the cost for the outpatient visits is cheaper for ARP, but the overall costs actually seem to be higher. So, next slide, our background. Okay, so as health economists would know, the healthcare expenditures are rising in Canada, and 2/3 of healthcare expenditures are chronic diseases are accountable for 2/3 of those expenditures. And over the past decade, chronic diseases have been increasing. So there are safe and cost-effective interventions that for chronic diseases, but only half of patients are really receiving them as a result of a lot of healthcare system barriers, specifically including physician compensation models. Next slide. Okay, so physician payment is governed under it falls under the economic theory of principal-agent theory, which all sort of payment models and contracts fall under. So you have the principal, or like an employer type person, who's paying or has a contract with an agent. So in this case, where the principal would be a healthcare organization like AHS or a hospital, and then the agent would be the physician. So the idea here is that the way the principal is paying the agent is intended to align the healthcare organization's goals with the actions of the agent, the physician. So the different actions or physician behaviors that we're interested in our research are the types of patients seen, frequency of repeat visits, the delivery of guideline recommended care, and efficiency or healthcare costs. So we have the patient in the center, which, sorry, the colors aren't super clear on this picture, but the patient at the center represents, while they might not be part of this principal-agent relationship, the goals of both the health organization and the physician, really should be aligned with also the patient's goals of getting improved health. So, next slide. Okay, so there are a range of different payment models just beyond the salary-based model and the fee-for-service model. Traditional fee-for-service is where you are paid for each service that you're delivering. So that, again, incentivizes maybe a higher volume, but wouldn't necessarily incentivize coordination because you make more money if you do all the services, right? Rather than sending them to somebody else. So another model in Canada is an enhanced fee-for-service, which is where maybe you're predominantly paid fee-for-service, but then you have sort of a additional payment rate for doing something else, like seeing a certain target population or working in a rural area, for example. Then there's a range of alternative payment models, which might blend a number of different things, including capitation, which is where you're paid for each patient you see, maybe some sort of time-based payment, like similar to the ARPs in Alberta, where you're paid a set amount for the time you spend doing clinical care, then you're also paid to cover your educational and research time as well. And then you can combine different aspects of these.
So I take that you're using that one as sort of a generic category where there's a lot of different items within it?
It's a big one.
Okay.
Yeah.
Sure.
Yeah. And then we'd have the more traditional salary model where you're just paid a set amount per year, which is how I'm paid, and probably the rest of you, a lot of you are paid too. So, Ian, also, thanks for interrupting me, Tom. If anybody has questions as we go, please feel free to interrupt. So in Alberta, the majority of physicians are paid fee-for-service, about 86%. But as containing cost is an important thing for the province and for across Canada. There's been experiments in different alternative payment models and the academic relationship plan, where physicians are compensated for their clinical and research and education time, started province-wide in 2004. And at this point, about 700 physicians are paid through that. There are also some clinical ARPs, but that's not what we're focusing on today. Next slide. Okay, so what we've learned, so I'm also, another part of my work is looking at a systematic review of specialist physician payment. There's been some primary care payment reviews, but which we're also working on updating. But so there hasn't been one that focuses on specialist physician payment. So of the studies we found, which are actually not a lot, and they all have controlled before and after designs or interrupted time series designs, we found from those studies that fee-for-service is definitely associated with increased healthcare utilization, but the impact on quality isn't clear. There's a lot of different outcomes that these studies look at. Some of them are looking at quality, but some have found no effect on quality. Some have found some effect. So there's really a range there, and no studies have looked at the effect on healthcare costs. Okay, so our objective is to determine the association of payment model, specifically fee-for-service or ARP, with outpatient visit frequency, quality of care, and costs for chronic disease patients who are newly referred to specialists. So hopefully, there hasn't been an empirical study of the ARP model, so hopefully we're adding to that Alberta's understanding of the ARP, and also, though our study actually wouldn't fit into the systematic review we're doing, it is adding hopefully to the literature in this area.
So can we just dive into shyness content? Visit frequency.
Yeah.
So what's a good result here? More or fewer visits?
It depends. So it would depend, because both fee-for-service might be incentivizing doing more, but on the other hand, there you have the risk under a capitation or salary model of not doing enough.
Right.
So I think we can't really know what's the right amount, but we can show the difference.
So you're not going to try to link frequency to appropriateness here at some point?
No, I'm not going to.
Good.
So we did look at the frequency for people at higher risk and people at lower risk, and you might expect them to respond in different ways for those kinds of patients. But I'm not going to say what's correct. Okay. Oh, yes. Sorry, yes, I will repeat the questions. That question was like how we were defining visit frequency and if it was connected to appropriateness. So, okay. All right, so jumping into the methods here. All right, so the data that we used for this is from the Interdisciplinary Chronic Disease Collaboration Data Repository. So this is a pretty awesome database that I'm lucky to be able to work with, that links lab data with administrative data for all Albertans since 1994, and then the most recent data that we've been using goes up to March 31st, 2015. So this includes labs, pharmaceutical drugs, hospitalizations, ambulatory care visits, physician claims, and all that good stuff. So the challenge with it, though, is that there wasn't a variable to consistently identify AR payment until 2011. So that's why we haven't, since it started in 2004, but we couldn't always identify people until 2011. That's why we weren't able to do a pre-post type of design here.
So, but you did include data beyond 2011.
We started in 2011.
Okay.
Yeah, so
and for physician claims, you use the shadow billing and the ARP physicians?
Yes.
Okay.
Yep. So the population that we looked at was adults with diabetes or non-dialysis CKD who were seen by specialist physician Calgary, Edmonton from April 1st, 2011 to September 30th, 2014. So we folks for, as far as how we were defining specialist physicians, we included nephrologists and internal medicine physicians, and also intended to include endocrinologists, but we found mostly they were billing as internal medicine. So we then defined diabetes specialists as a type of internal medicine physician who was seeing at least 30% of their patients or claims for diabetes, and about at least 50 of their patients per year were seen specifically for outpatient diabetes visits. So this group that we were looking at, we wanted to look at people who are newly referred to see specialists. So we defined a new referral as someone who hadn't had a visit with that same physician or that sort of category of physician in 4 years prior to the index visit that got them into the study cohort.
Is that valid? So you're trying to determine incidence here of visits, and so you chose 4 years rather than.
I chose 4 years because Brenda Himmelgarn did it.
Okay.
Yeah.
So that's what we've done before.
Yeah.
So the notion that's long enough to wash out the, the infrequent visitor to the same physician.
Yeah.
Okay.
Does that seem clear
Sure.
to you? Okay. Oh, sorry. Somebody just asked why we had used 4 years as a time period. Okay. So, and then we excluded. Sorry, I'm still on the other side. Sorry. We excluded people who started dialysis prior to 90 days after their index visit, people who had had a previous kidney or islet cell transplant, and people whose index visit appeared to be a preoperative visit. So like they were consulting a physician before they had a surgery. So these people, we just thought like that kind of visitor, that kind of person wasn't going to represent really the typical patient having chronic disease management. Okay, next slide. All right. So our primary outcome of interest was frequency of visit with the same physician. So that's the frequency of subsequent visits after their index visit. And then we also looked at quality of care, which we defined as guideline recommended care based on what preventive medications they were receiving and screening measures. And then we also looked at hospital admissions and ER visits for diabetes specific and chronic kidney disease specific ambulatory care sensitive conditions. And then costs. So next slide. So the other variables, our explanatory variable was the physician payment model. So if they were fee-for-service or ARP, and then a range of covariates of patient and physician characteristics. So the patient characteristics included demographics and including socioeconomic status, and we also look at primary care attachment and illness severity and other comorbidities patients had. And for physicians, there wasn't that much available in the administrative data that we had, but we looked at like the type of physician, how much they were working, how many clinical days they were working, and like how many years they've been practicing that we could see within the data set that we had and where they were practicing.
So, Amity, would you agree that 700 people that were in the alternate funding plans were, in fact, different types of physician, higher specialty concentration, subspecialty concentration, academic positions, etc., simply because of where the ARPs were? Very few primary care docs.
So I only looked at these patterns among the nephrologists in diabetes and internal medicine people that I see, but yes, there are differences between them that I will show you. Did you have something?
Okay, I got it. So then, thinking specifically about nephrology, those that were on ARPs and those that would not be on ARPs would all be included here.
Yes.
Or something service types. Okay, got it. Yeah.
Yeah. So because the physician was identified. Sorry, the question is about are there differences between physicians in ARP and fee-for-service, basically, which I'll get to the details in a second. But we didn't start with identifying the physician. We started with identifying the patient visit and who their provider was.
Got it.
Yeah. Okay, sure. Okay, so next slide. Okay, so the most nerdy part. So so when we first looked at some preliminary characteristics of the patient, we noticed that the groups of people seeing ARP and fee-for-service physicians were significantly different. So we decided that to get more better estimates of our outcome measures, that we would do propensity score matching, which should theoretically like mimic, it should match patients so that the people in the treatment groups and the control groups are basically balanced, which would kind of be mimicking a randomized control trial. And then we didn't then do any additional regression modeling to adjust. We just looked at the differences in outcomes between within the matched cohort. So to do the propensity score matching, we first did a logistic regression model to estimate the probability of being seen by an ARP or fee-for-service physician. And in that model, we included both patient and physician characteristics measured at the patient level. And then that model was very predictive. So the C statistic was 0.86%. So I think over 0.7 is pretty good. And then we matched 2 fee-for-service to 1 ARP. Sorry, and when I say that, I mean like a patient who's seeing a fee-for-service or a patient who's seeing an ARP physician. And then we did use replacement. So like if someone, so all the ARP patients were in there, and then if like a fee-for-service person was matched, they could be matched again to a different patient. So once we, to estimate our outcomes when we're looking at the payment model relationship with visit rates and the ambulatory care sensitive conditions, we used an incidence rate ratio estimated with a Poisson model. And then for payment model and guideline recommended care, we looked at risk ratios, which we estimated using a modified Poisson with generalized estimating equations, which account for the matched nature of the sample. And then for costs, we used the amount paid per claim, but if there were ARP physicians, we then used sort of the system estimated shadow billing costs, as we already discussed. So yeah, Chris, to clarify with replacement, sorry, I was asked online to clarify the with replacement point. Just like, so once you get the propensity score for each, so this is still new to me, so I apologize if I'm not explaining it well, but once you get the propensity score for each person, so if we had an ARP patient and we found a fee-for-service patient that matched with that patient, that didn't then like exclude that fee-for-service patient from the data set. They were still in there and then could be matched with an additional ARP patient. So was okay. Thank you. All right. Okay. All right. So our exciting results. So overall, we found about 112,000 adults that had diabetes or non-dialysis chronic kidney disease who were seen by one of these types of specialists in Calgary and Edmonton in this time period. And sorry, just to get back to methods for 1 second, we did only include Calgary and Edmonton rather than rural doctors because the ARP is only in Calgary and Edmonton. So that's one of the changes from the Alberta Health Economics Study Group, where we had been looking at everybody in Alberta, but we limited it to just physicians in Calgary and Edmonton. Okay, so, and then from our exclusions, we dropped about 14,000 people. Okay, next slide. Okay, so if we look for a little while at the characteristics of the unmatched cohort, you can see, this isn't everything that we looked at, but you can see there was some balance. So everybody, the mean age was over 60. There was about 3% First Nations, and then most people were in an urban setting, though some people were in a rural setting and then would have come into Calgary or Edmonton to see a physician there. But you can see, so the standardized mean difference helps understand if there's a balance between the fee-for-service and ARP groups. And if it's less than 10, it's like a decent balance. If it's over 10, you would be concerned that they were different. So we see here, like the female, there's much higher proportion of females going to ARP physicians, for example. And then if we look at some illness severity characteristics in the unmatched cohort, we see more differences here. So there are a much higher proportion of diabetes patients going to see fee-for-service physicians, where it looks it's pretty balanced between people with sustained A1C over 9% is kind of a way to estimate if your diabetes is not well managed. So there's kind of like the sicker patients with diabetes. So that's pretty balanced, but you can see then the difference. There's a lot more people with chronic kidney disease going to see ARP physicians, and then more advanced CKD is when you have like generally a kidney function of less than 30%. So those are sicker CKD patients. So they're more often going to ARP physicians. Yeah, Eldon.
Just with the sustained A1C, so that's not baseline A1C, that's prior to the first visit over a certain amount of time?
Yeah, the question is about how sustained A1C was defined. We looked at, I think you had to have 2 A1Cs less than 9 within, over 9% within, I'm blanking on the amount of time before the visit. But yeah, so that's different than the baseline A1C measure.
Can I just clarify the payment right at that point in time? My recollection is that all of the nephrologists in Calgary, whether they were inside the university system as GFT or they were community-based, were on the ARP. Whereas in Edmonton, that was only true if you were GFT. And if you were community-based nephrologist, you would not have been in the ARP. Is that correct?
No. This is about a 70-30 mix. And Edmonton, the difference is everybody at University of Alberta Hospital is in the ARP, and everybody outside is Feeforservice. In Calgary, everybody rotates around the city. It's pretty much, as you said, there's about 6 out of 20 physicians that are self-Feeforservice.
So we're going to, so it would be natural for me to expect that those that had got more and more disease severity and complexity would eventually gravitate towards the so-called subspecialist nephrologist, which in Edmonton is a mixed bag of Feeforservice and ARP, but in Calgary is all ARP. Correct?
Not all ARP. It's about 70% ARP and about 30% Feeforservice.
In Calgary as well.
Yeah.
Okay, so not everyone is in.
But you are correct that there's a higher proportion of nephrologists who are in the ARP. So also that.
Yes, okay.
Yeah, so.
But not really different between Edmonton and Calgary as I checked away from ours.
And actually, there's central referral during this time. So referrals often come in and they go out to the docs based on next availability. You don't choose your patients by and large, although you'll see that it might not be entirely true.
Okay. Sorry, we were just having a conversation over here about differences in ARP in Edmonton and Calgary. So there's also a question online about how First Nations were identified through the data. So in the registry data that we have a variable that identifies that. So that's how. Okay. So also so generally it seems like ARP physicians are seeing sicker patients, as you can also see with the higher comorbidities. We're also going to see ARP physicians. So this is what drove us to want to do the propensity score matching. So there was the populations were similar. Next slide. All right. So then if we look at the matched cohort, we can see. So female was the one that was most different before, so we can see that this is balanced now. And then if we look at the illness severity, they're much closer than they were in the unmatched cohort. So the standard differences are all under 10. So now we can feel more comfortable that we're really seeing a treatment effect in the outcome differences rather than baseline differences between the patients or the type of patients that physicians are selecting to see or are getting referred to those physicians. Yep. So all patient characteristics that we had, so the ones I showed you plus additional some additional ones, and then also physician characteristics that we measured at the patient level. So like what the physician's location was, what type of physician they were, how many years they've been practicing. Oh no, I don't use that. So those as well. Sorry, the question was what I had matched on, done the propensity score matching on again. Okay, so hopefully this will answer some of Tom's questions. So in terms of, this is physician characteristics at the physician level. So I took this from the patient level data. So over the whole time period, there were 539 different physicians who were over 80% internal medicine. But then if you look at the breakdown between fee-for-service and the alternative relationship plans, I think the most striking thing is that a much higher proportion of the ARP physicians are kidney specialists. So then maybe we could have thought some of like the higher proportion of CKD patients seeing ARP might be driven, just by the fact that there are much more ARP physicians who are nephrologists. Okay, so the next slide, if we look at some, additionally, since ARP physicians are paid for their clinical time as well as their research and academic time, we wanted to look at what the clinical workload was, and so we define that as the lower tertile. Sorry, my notes got a little mixed up here. So the lower tertile is working about fewer than 100 days, and the mid tertile is about 100 to 200 days, and then the highest is like 200 to a full year. So that's like the days that they had a claim on. So I think, again, we see here, which makes sense because we didn't think that ARP physicians probably are working as every day of the year, so a higher proportion of them are working in that 100 to 200 days per year range. Sorry, is that days over a year over the data period? That was within 1 year. Just answering a question. Okay. All right, so the more exciting results. So in our primary outcome being the frequency of repeat of outpatient visits that the physicians are bringing patients back for after the index visit. So across the board, we see that ARP has a lower visit rate than fee-for-service, which theoretically makes sense. So overall, and then if we're looking at the incidence rate ratio, which is at the bottom, we these are all significantly different, and so we can understand that patients with ARP physicians had a 9% reduction in the rate of coming back for a follow-up visit. For people with diabetes, it was a 17% reduction, and with chronic kidney disease, it was a 7% reduction. So then we see this pattern, same pattern, generally for patients who are higher risk of adverse outcomes. Sarah, can you change to the next slide? Thank you. So we do see with the more advanced CKD, there's not a significant difference. So which you might expect, if patients are sicker, you might think they should come back in for more visits. So again, we don't know the appropriate level of visits, but you'd think maybe they would need more visits if they were sicker. So we do see that there, but there's still a 25% reduction in follow-up visits for people with sustained A1C over 9%, for example. And then we see, again, the same pattern with patients who are at lower risk of adverse outcomes. So this is patients with fewer comorbidities and who have well-managed diabetes and less advanced CKD. So looking at our quality measures. So this shows the proportion of fee-for-service and ARP physicians who are whose patients are on preventive medications in 6 following the index visit. So these drugs tend to be used for reducing, we're talking about this morning, heart attacks and risk of death. So they're important preventive medications. So they are these are not statistically significantly different between the 2 payment models at all. So maybe they're lower than we'd want them to be for all physicians. Okay, so then if we look at the next slide, which is these are screening measures. So these might not be as significant as quality measures as these important drugs that are preventing you from dying. But so we do see there was statistically significant differences in these measures, but as you can see, they're kind of, at least with the urine albumin screening, sometimes it's better for ARP, sometimes it's better for fee-for-service. And then the eye exams and A1C measurements are specifically for patients with diabetes. So these differences, while significant, don't seem to be at that clinically meaningful. Okay, all right. Help me remember Chris has a question for later. Okay. All right, so then, however, there is more of a difference when we look at the admissions to hospital and visits to ER for ambulatory care specific conditions. So these are conditions that you hope that if someone does have well-managed disease, they wouldn't have to be going in for hospital and ER visits. So there isn't a difference for CKD specific rates for patients with CKD, but we do see a difference for people with diabetes for diabetes specific ambulatory care sensitive conditions. So patients with ARP physicians had a 21% increase in hospital and ER admissions for diabetes, ambulatory care sensitive condition. So we can interpret that as like for 100 patients, there'd be 6 extra visits per year. Next slide. Okay, so then we again just started looking at the cost data. So we do see in this first line we can see like with your primary specialist, who's like the nephrologist or internal medicine physician who these patients are seeing, the outpatient visits specifically are $366 for ARP and then $376 for fee-for-service. So this is in the 1 year following the index visit. So, and then the specialists and primary care visits combined together are higher for ARP patients seeing ARP physicians than they are for fee-for-service. Most of that is driven by the specialist costs, which are about $3,000 compared to like the $1,000 of the primary care. Chris, I'm just going to come back to your ACSC questions at the end as well. Okay, so if we look at the other costs, so we didn't look at every possible healthcare cost we could in the data. We tried to think about categories that would be relevant for like maybe what the primary specialist could control. So these are so we looked at prescription drug costs for like typical chronic disease medications, and then allied health clinics. So like what the costs were of people going to kidney clinics or diabetes clinics where they're the allied health professionals that might be helping care for these patients. So we can see across the board here, except for prescription drugs, the costs are higher for ARP patients who are seeing ARP physicians. So I don't know if these are statistically significantly different, like some of the differences are pretty small, but when you add them together, it is a lot higher for ARP. If you include this with the cost that we showed on the other slide, it's at least $1,000 higher for ARP than fee-for-service in the year, again, the year following the index visit.
Well, what's relevant is it's not lower.
Yeah, yeah, it's not lower.
Can I ask,
Sure.
How are you calculating the cost of the ARP service visits?
So, do you want to? So the first way we decided to do it was there was this like system cost estimate that we can apply. Should I give more details? No, that's okay. So that's what we've done so far. We have, if people have other ideas about how to do this, I'm all ears. So we also tried a method where we tried to estimate a typical cost for ARP physicians based on like their salary and a relative value of all of the services they would be providing compared to fee-for-service. But we haven't we're still working on that. So, and if people have other ideas, I think.
Well, based on Sarah Cunningham's work, you ought to have a certain level of confidence of using the shadow billing and turning it into scheduled medical benefits extrapolate from that. I mean, because quite frankly, fee-for-service billings are not really much more accurate than the shadow billings anyway. So they all have a certain misclassification or error in them.
Mm-hmm.
But I guess it's the fact that the direction is not what everybody would like to claim from, but that's why it's
Right.
so
Yes.
important. Right?
Yeah, exactly.
So the Department of Medicine is going to have a look at its full-time clinical members and compare the shadow billings to their incomes and give us a sense of what proportion or percentage above or below they are. So that'll speak to all billings. The problem with this is it's just a very small proportion. Most specialist billings are inpatient, so this is a challenge. So if anybody has any suggestions, that would be great. But that'll give us a real sense of whether if they have been in the fee-for-service system, they're billing more than they're actually getting paid.
I have a question
Yeah, Eldon.
about patients who are identified by their first visit physician, but can they go to other types of physicians? So could you go to an ARP physician the first time and then a fee-for-service the next time, and if you're a different fee-for-service physician the third time, and then back to ARP for a while?
So the question is, like, if your initial physician is ARP, could you have then also gone to afterwards a fee-for-service physician? Yes. So, but I'd only be measuring your return visits to the same physician you saw on the first visit. That's the way we did it here. I think there, we could have looked at additional visits with that same physician type. Like, did they maybe go to one doctor first and then not like them, and then go to somebody, a different nephrologist, and then keep going back to that one? Yeah, that's a possibility. So that would be captured in terms of the cost in the other specialist costs, but we wouldn't have captured that in the visit rate.
So if I thought a patient was too difficult, and then I just never saw them again and made sure they were somebody else's problem, then it would look like I didn't have them come back at all.
Yeah.
Because the silent part in this is we don't know what's going on in the primary healthcare side of this.
That's true.
Whether you're an ARP or a fee-for-service nephrologist, are you doing a nephrology job, and are you using more primary healthcare to supplement, or aren't you? And I don't think we know that, right? In this.
We don't have visits. We looked at attachment to primary care, but I don't have that data. And we looked at the costs. Oh, sorry. You can go. Okay. The cost. Yeah, sorry.
We can talk about at the end is there's referral patterns we're dealing with here as well, that sometimes certain kinds of primary care doctors will be referring to fee-for-service doctors all the time, and there's a relationship there, and that may be driving some of the differences that we're seeing. But the costs for primary care are in here. I mean, it's interesting that ARP docs costs for other specialists in primary care is higher.
Yeah, but now let's just think through the incentives here for just a moment. If I'm an ARP specialist and I'm a little on the lazy side, I want to collect all my ARP money and do as little as possible. So I'm not going to see the patients, on your point, or I'm going to send them on to someone else. So I would expect the concentration of services to come from other than me to be higher in the incentives for ARP. Whereas fee-for-service, hey, bring them on because I get paid every time they come. So this is interesting. So in other words, ARPs are more likely to slough off elsewhere into the system. Fee-for-service is likely to hog it for themselves.
I mean, the one thing
You
that's
could interpret it.
slightly concerning is that the patients in the unmatched sample seem to be quite a bit sicker. And Amity's done some other work. So are we just unmeasured severity, or as you say, the ARP doctor doesn't see them again? So actually, the family doc has to refer them on to somebody, and they realize the ARP docs aren't doing the job, so they're sending them to a fee-for-service specialist.
Chris McCabe says the incentive could work in the other direction from Tom's proposal. It may be that the ARP will not protect their income and hence refer appropriately.
Well, I think your incomes are very well protected.
There's higher costs in hospitalizations and visits to other alternative healthcare providers, like nursing clinics or others. I think that's kind of indicating.
Can you go to the
they're
next
trying
slide?
to push some of their work towards either emergency or other healthcare providers.
Yeah, we had looked at proportion of people going to like a kidney clinic. If you maybe the nephrologist we thought maybe only ARP nephrologists would be sending them there. So we do see that both fee-for-service and ARP are using those. So I think that's good to know that they're a resource that's there. But yeah, it is a higher cost.
So you guys are looking at hospital admissions, ER visits for the episode admissions. Did you also look at total hospital admissions and ER visits? Because that also might speak to what Braden was saying about the unmeasured extra severities. If the ARP patients are coming to hospital and ER more frequently for non-kidney and non-diabetes related issues as well, that might also be an indicator of their general state of well-being.
Yeah. So the question was if we looked at total hospital and ER costs, not only for the ambulatory care sensitive conditions. We have not done that, but it's a really interesting point.
I mean, the ARPs are set up differently in Calgary. I think from Edmonton, the ARP, the fee-for-service docs generally work outside of the academic settings, and they don't have access to the allied health resources that the ARP physicians do. In Calgary, at least for nephrology, everybody has access to the same resources, but you'd expect there to be a higher use of the allied health clinic. So every time somebody touches an AHS clinic, it gets recorded. So that's maybe not a concern. Some of the other categories are potentially a concern. They're seeing more specialists, and that they're having, again, patient calls up the ARP office and says, my blood sugar's out of control. The fee-for-service doctor might be more likely to bring them in. The ARP doctor might not respond, and so the patient ends up in the emergency. It's hard to attribute the causes, but these are some of the things. Do you want to? You've got a few more slides,
just
and then
finish. Sure. Yeah, I'll rush through the summary since you guys are so geared up to talk. Okay. Okay, so just in conclusion, summary of the findings. So we are seeing ARP payment models associated with a lower number of outpatient visits. Guideline recommended care is similar. We are seeing fee-for-service specialists having a lower rate of diabetes-specific ambulatory care-sensitive condition admissions. And the costs for the outpatient visits are less, but for most other healthcare costs, they're higher for ARP. So just to review some of the limitations of the study. So we did, in the introduction, Braden explained like why we set up the population the way we did, but because it's adults with only diabetes or CKD, seeing nephrologists or internal medicine physicians in Alberta, there might not be a lot of generalizability outside of this population. And then I think even though we did do this propensity score matching, there might still be some unobserved differences in patients and maybe more importantly in the physicians. And, we did try to control for the, or take into account the physician characteristics that we could, but there might be other physician characteristics that are contributing to why they choose to go into an ARP model. Like we don't have physician gender, so I've seen some other research where women are more likely to go into the alternative payment academic relationship because they want to have more flexible schedules, for example. And then are there other things that are happening in the system? So we've mentioned a few times already, like who are the primary care physicians that are referring these people, and what are their patterns of referral? And we can't tell that in the data, but I am planning to do some follow-up qualitative work and talk to primary care about how they're referring people. So just kind of harkening back to our key messages and thinking about policy implications moving forward. So as chronic disease rates are increasing, as are costs, so trying to figure out how to improve quality and value of chronic disease care is important to the sustainability of Alberta's healthcare system. And while we do see the ARP payment model is associated with a lower number of outpatient visits, other costs and quality, other costs are higher and quality seems to be similar. So improving the quality and value might not only have to do with the payment model, but we might need to think about other strategies like accountability. How can we increase the accountability of these physicians, whether they're fee-for-service or ARP? So could performance indicators be included in the contracts to maybe improve, like the prescribing rates were maybe lower than we wanted to see? Could we include those as performance indicators in contracts so that those would be improved across the board, for example? So great. Well, thank you, everybody in the room and online. And now we can get back to our exciting conversation. And there's some questions that have come up online, so I don't know how we want to balance. Maybe we could do thank you. We could do a room question and then an online question. Yeah, let's do a.
Chris had some questions.
Chris had some questions. Chris has all right, Chris, are there floor and/or ceiling effects in scope for change based upon patient characteristics and system capacity, like waiting lists?
So, I mean, these people are people that actually have interacted with the physician. It would have been excellent if we could have had an outcome around access, like how quickly did they get in to see the physician, but we don't. That's not, when the primary care physician puts in the referral, is not recorded in the system, so we don't have wait times and that kind of access variable.
Okay. Great. Room question?
Room comment.
As I recognize you said you couldn't actually determine how physicians are paid until 2011. Are there sufficient numbers of physicians in this data set from 2011 on that you can tell if physicians change payment mechanisms, or if they transition from fee for service to ARP during that time period?
There's a small, so the question is, you see within the data 2011 on like if there are changes between fee for service and ARP within the positions we have. There's some change, but it's pretty small. It's not enough to do.
To look to see how.
Yeah, but good idea.
So on the cost difference thing, I don't know how much time you spent on this, because I think you said that you only recently got data. But I'm just curious if you've tried to disaggregate, not like look at different segments of the data. So, for example, are there certain geographic effects that are driving these costs, or because of the structural differences that Braden implied with the nephrology group between Calgary and Edmonton? And the second question I have, or the second piece I would look at, is if there are differences in cost between the three, I think it was three specialty groups that you looked at, and to give you some sort of sense of how to move forward to tackle that issue.
Yeah, that's a good. The question was about have we like looked in more depth at differences in the costs, like for example by Calgary and Edmonton or by physician type. We haven't done that. I think that's interesting. I think we did. Oh, what was I going to say?
So we were going to repeat it. One of the things we haven't fully satisfied ourselves with yet is, as you saw, there's more nephrologists in the ARP, and so there's going to be more people with advanced kidney disease in the ARP, and those are quite expensive patients. So you're right, we can repeat that costing analysis in, well, either just people with kidney disease or in people who are seeing kidney doctors, and do the same thing with the rest of the patients. Some people have both. So these things, it's a good idea. That one was on our list. We could certainly look at it by geography as well.
One thing that we did have planned is like, so what I showed you was the first year, the cost after the first year after the visit, of the first year after the visit. But we'd also want to look at the second year after the visit, because you could
get worse though.
It could get worse. You might think it could get better because like if they're having, like if the quality is improving, though we did see the quality doesn't seem to be different. So yeah. Tom, yes, and then I should take an online question. You can go.
So this is perhaps a comment. I really like what you've done, and I think it tells us a lot, although some of it is not in the direction I might have expected, which is kind of always interesting. For me, what would make this more robust is if I had a clearer understanding about the extent to which the patient was bouncing in the system to the primary care side of the house, and just how much of what we're seeing is different, so that the question is not just is utilization any different or the frequency of visits, but is the intensity of use in primary health care any different, or isn't it? It has cost implications, of course, but it also tells me about what the role of the kidney doctors are, because there is always been the perception that if you're a fee-for-service specialist, you're going to indulge in a lot of primary health care you shouldn't indulge in, and not pass the care back to the primary health care doctors. And you can answer that question right there, right now, if that indeed is the case. The bias would be that fee-for-service patients or fee-for-service specialists are not going to use primary health care as much. And I bet you that's not what you're going to see. I think you might end up seeing the reverse.
So I guess what we'd have to see is look at the rate of primary care visits before the specialist visit and compare it to after, considering whether it's an AR or a fee-for-service doc. There's differences in the types of primary care docs, I think, that are referring to.
Yeah, I can't think out loud about the methodology, but something of that sort that would simply give you a sense for how much what you're seeing right here is just movement of the patient to another kind of provider. I think that there's a lot of information in that. You have some of it already.
Yeah.
You're looking it up.
Yeah.
Well, it doesn't have to be, but it's just hard. It's going to be hard to collect the data. That's what
I like the idea. Okay, let's do an online question. Oh, sorry, I'm blocking my face. This thing. Oh, Chris is typing. Someone did ask if we looked at the reliability of shadow billing. Like we haven't done that in this project, but as Tom had mentioned, some additional research that had been done here that did look at it, and it was at least shown to be reliable for diabetes in the data set that we're using. So
compared to chart review. So
okay. All right. Chris, do you have a preferred question that we would answer? I'm sorry, I think there's, yes. Okay, all right, thanks for your summary. Should I read Chris's summary content? Okay, Chris writes a summary comment. 1, if patients in the ARP group could also have seen fee-for-service, then you can't attribute differences in utilization. 2, it would be great to unpick the appropriateness of health system utilization because you can't say the quality of care is equivalent at that moment. Okay. Interesting.
Yeah, remember the repeat visits were to the same provider, but you're right, it doesn't, if they then see another physician who the quality of care isn't necessarily due to that specialist, it could have been, you're right, they saw a second specialist who actually was the one that put them on that ACE inhibitor. But the visits were just to that same provider, which that provider does control. I think this is just part of the overall picture. Amity's got some work looking at severity of illness of people that are seen. And there's a huge attribution problem here. And then there's the types of patients that are referred on from primary care. And I don't think it's that primary care refer to one type of an ARP doctor, a fee-for-service, but in the northeast of Calgary, let's say, there may be more fee-for-service docs, and there may be more high-needs patients, or vice versa, depending on the city. So that was why we tried to make this as homogeneous a sample as possible. But that's been some good ideas around looking at total hospitalizations and things.
Jesus. Great work.
Any last question in the remaining 90 seconds?
I was thinking the higher rates of outpatient and allied health service providers on those physicians. Is it possible that because they don't work full time doing clinical work, that it would be more difficult for patients to schedule a regular appointment with them, so they might end up in these other providers?
Yeah, I think so.
Ambulatory care as well. That's the other piece I thought is if they have lower clinical time.
Well, just how does that work? Like for you, like if someone's your patient, then would you see them again, even if you're not?
Yeah. The patient is going to get an appointment until next week with an ARP provider because they only work 2 days a week. I would go to my friend.
Yeah. Yeah, the visit.
You're not capturing allied health as provided in private. And it is.
Correct.
So it's not coded. So if someone goes to a private, like a fee-for-service endocrinologist that has their own private clinic and has hired dietitians and nurses and that sort of thing, there's no way to know that they've been seen by them. So that might not be, I mean, that might not be as much of a difference. Does it happen often though? Yeah, and the endo, they have education and stuff like that.
And primary would have resources locally that we're not capturing in this. These are just the AHS owned clinic or operated clinics. So, yeah. It's great when the research poses more questions than answers. All right, Amity, thank you very much.
Thank you. Thanks, Sarah, for the slides.
Yeah, nice job on the slides.
Great. Well, thanks everybody online for coming and your questions.